Good evening, everyone. We welcome you all to OrthoTV Online in association with Orthopaedic Research Education Foundation. To introduce today's speaker and the topic, I hand over to the Secretary of OREF, Dr. Janki, Bhadani.
Thank you so much, sir. Good evening, everyone. So welcome to the platform of Orthopaedic Research and Education Foundation in India. Today we have Dr. Anil.K.Bhat from KMC Manipal. He is Associate Dean, Professor, and Head of the Department of Hand in KMC Manipal, and expert of the topic like brachial plexus palsy. He has taken few of the classes, very difficult topics for the postgraduates. So I welcome Anil, sir. Over to you, sir.
Thank you, Dr. Janki, and thank you to OREF for this invite again. It's nice to be back again. I think this is my third time. John sir, I think, will join us later. So I'll start my presentation. It's visible, right? The screen?
Yes, sir. Very clear.
Yeah. Right. Good evening, everyone. This is basically nowadays a lot of long cases are being kept in the DNB program. I mean DNB exams, especially of brachial plexus injury, and even in the MS exams, or it's kept sometimes as a short case also with very specific neurological deficits. But clinically, in a clinical practice, again, it's very, very important to understand these patients. And a lot of times these are missed injuries. And so, especially with polytrauma patients, like this patient with the road traffic accident, swollen limb, we got a consultation by the ICU asking for ruling out if there's any vascular injury or any compartment syndrome in this patient. Patient was not moving the limb and it was swollen. And so one of the common diagnosis was compartment syndrome was thought of. But when we examined the patient actually had neurological deficit, and there was a complete brachial plexus injury of the entire limb in this patient. So there could be, especially in an unconscious patient, multi-trauma patients, these injuries can be often missed. And so clinical examination is very, very important. And if you look at the incidence itself, most of them, and they can have combined injuries, both global palsies and with other kind of injuries. Most of them are supraclavicular injuries, at least having one root avulsion, and can involve C7, C8, T1, which are the lower roots, which are difficult to access. And also they develop, a lot of these patients develop chronic pain. And that's one of the symptoms patients can come with. So you should know some of these terminologies, especially when you get a case. The first thing we ask is, what type of injury is it? Is it a preganglionic or a postganglionic injury? And most of the time, preganglionic injuries are basically one which are avulsion type, means directly from the cord. I mean, the roots are avulsed directly from the spinal cord. So these are avulsion injuries. And the postganglionic injuries generally happen outside the foramen, and usually we call it rupture. So these are two terminologies we use, avulsion and ruptures, very commonly when we talk of management itself. And there's also whether it is global palsy or it is upper brachial plexus or lower plexus palsy. So this is again another classification. This most of you know. So is the entire limb flail, or is it upper brachial C5-6 classically, or it could be a C5-6-7 is an extended upper palsy, or a lower plexus, usually C8-T1 kind of a thing, classically presenting with a claw kind of a deformity. The importance is that rupture is extraforaminal, which means that axons are available for us to do some procedure. They're still connected to the spinal cord, but avulsion is where it's completely disconnected. So the repair is not possible as of now, at least. And so you need to think of different strategies. The preganglionic injuries, again, a very common question asked, what are the clinical signs? The first and foremost you should be talking of is harness sign, winging of scapula, parascapular muscle wasting, absentinal sign, normal axon response when you do the axonal response, and global palsy. A lot of times, majority of these patients are global palsy patients, and they might have profound neurological pain. So these are 6 or 7 signs you should be looking for. We don't do the flare reaction most of the times, but clinically, at least horniness and winging and other things have to be looked for. When you start the patient inspection, look at the attitude, the way patients see. This is an upper brachial plexus kind of injury. You have the typical policeman stiff hand, what you want to call them, and how they, use that limb. So it's the shoulder is paralyzed, elbow is paralyzed. So elbow is kept in flexion, extension, and shoulder again, abduction is absent. Vis-a-vis this global palsy, where the patient always supports the entire limb because the entire limb is paralyzed like this. So looking at the attitude itself, you can make out what kind of palsy are these. As I said, Horner syndrome, very, very important sign, highly specific, but quite not very sensitive. Ptosis, meiosis, and enophthalmos. These are the classic signs you look for. And basically, the other two, anhidrosis and loss of ciliospinal reflex, these are seen basically in CNS disorders, actually. More of central kind of a finding, but otherwise, the ptosis, meiosis, and enophthalmos is very, very specific for the preganglionic injuries. Winging of the scapula, all wingings of scapula is not, upper brachial, global preganglionic kind of injuries. Isolated winging due to just serratus anterior nerve palsy can be there. And if you see the patient, you'll see the winging like this, okay? But here, if you see this, the rhomboids are not paralyzed here. The spine is at the central here, compared to global palsy patient, where you would see that there is some amount of wasting which is happening, and there's a gross wasting here. And if you see the distance, the scapula is kind of moved away here because even the rhomboids are paralyzed here. So the distance from the midline you should see, and the difference you have to see. That's very, very important for you to differentiate between a global palsy because of rhomboid wasting here versus isolated serratus anterior palsy. Some of the inspective findings, especially in global palsy, is gross wasting. Right from the root of the neck, you should check the clavicle, especially because they might have injuries, associated injuries. So there could be clavicular fractures, you have, there could be malunions there, there could be non-unions there, and there is wasting of the muscles all around, right from the root of the neck down, all the group of muscles, and autonomic changes. If you see the skin of this patient, it is dry and scaly and shiny. So the deltoid is paralyzed, biceps is paralyzed. So all the group of the forearm is paralyzed. So always compare and check both the sides, and you will definitely find the difference, especially in the hand. As you come down to the hand, you will see the difference, the dry skin here compared to that side. And the scaly skin, see very nicely, you can see that some amount of edema because of chronic venous congestion can be there. So all these things have to be taken care of. Palpation, especially for associated injuries, you should look for clavicular malunions and the scar itself. Where is the scar? Is it tender, right? And you need to check for any kinds of associated injuries. And here, a lot of time, the pulse might be absent in a global palsy. So always check the pulse here during your palpation, because neurovascular injuries can happen commonly. Tinel sign is one important thing. So if you look at the Tinel sign for this patient, especially it is a upper brachial plexus. So a lot of times these are not global palsies. They are not preganglionic. So there might be continuity there. And you would see that some amount of Tinels can happen in this patient. Versus if you see these patients, global palsies, absolutely, there won't be any kind of Tinel sign, and patient won't feel any of these things. So if there's no Tinel sign, you should think of avulsion. And absence and lack of progression is much more conclusive than just presence and migration. So more important is not having it, and then you can definitely tell that probably it's an avulsion injury. Postganglionic injury are basically segmental. Either it could be upper or lower. Sometimes they can be global also, but no signs of preganglionic lesions you see. And predominantly, upper roots are involved in these patients. Neurological examination is the most important thing here, especially from the roots. You have the dorsal scapular nerve, basically talks of the serratus anterior. Okay, so how the serratus anterior moves is beautifully seen in this Ackland's video here. So this is the normal side serratus anterior. Basically, the forward flexion is the action. The origin and insertion, if you look, overhead forward flexion is the main action. The inferior part of the scapula moves towards the mid axillary line. That is what is the action of serratus anterior. And now if you see in this patient, in the upper brachial plexus, patient won't be actually able to, this is the normal side. If it's upper brachial plexus injury, patient, he can't abduct the shoulder. So you have to position the patient. So this is the normal side serratus anterior. Now in a parallel side, if you want to see patient, you know that he can't abduct the shoulder because deltoid is paralyzed. Okay, so which means to say that you have to position the patient in the way you want, and then ask the patient to do the action of serratus anterior, which is forward flexion, and you will start feeling the contraction. So a lot of times when we ask the students, how will you check serratus anterior, they will tell that push against the wall. But in a paralyzed patient, they can't push against the wall. So very, very important for you to make out that how to test these muscles. Okay, and versus in a paralyzed limb, again in a global palsy like this, absolutely the entire limb has to be supported for the patient, because patient can't do anything. And then we ask the patient to at least try and see if there's any flicker of contraction. This is how serratus anterior is tested. The second is rhomboids. So these are the two muscles arising from the roots directly. So rhomboids is basically hidden muscle here below this. So this is the levator scapulae. These are rhomboids, major and minor. And levator scapulae you can't clinically test, but then rhomboids can be tested by this particular action here. They cause they retract the scapula and cause downward rotation here. And so palpate the rhomboids during excursion like this. So this is the normal side. How do you palpate? So this is the exact amount of, I'm sorry with the turning of that video, but basically with the downward rotation and retraction of the scapula, you can actually feel the rhomboids contracting here. Okay, and compared to in the paralyzed side, I just shifted all these talks from another laptop. I'm sorry about this. So you need to position this patient here like this and then check for the contracture here. So this is called as the Kendall's test. But in a paralyzed patient, again, you have to stabilize this shoulder and ask the patient to at least try doing this and see if at all there's any flicker of contraction. So this is how you test for rhomboids. In the trunks, basically, there are nerve to subclavius, which you can't test clinically. But then you have a suprascapular nerve, which you can test because it supplies both the supraspinatus and infraspinatus. So this is the normal side. Again, sorry for that video. So this is the supraspinatus, especially the initiation of abduction, which is being seen. And you can, in the suprascapular fossa, you can feel the contraction of this. And this is the paralyzed side. And, just about he's able to make out, and there is absolutely no contraction. Again, this is on the global side. So all the global palsies, my assistant Dr. Ashwath is doing the test, and for the upper brachial plexus, I'm doing the test here. So again, position the limb, support the limb here, and see if there's any flicker of contraction happening in the supraspinatus fossa. That is in global palsy. Now, infraspinatus basically is again your classical, supporting this and asking the patient to do the external rotation. So this is what happens in the normal side. And in the abnormal, so you can feel the muscle contracting in the infraspinatus fossa here when patient tries to do external rotation. So this is how we check you can also check it in 90-degree abduction here. This is also external rotation in 90 degrees of abduction. And again, you feel the contraction here. And again, this on the normal side and the affected side, this is an upper brachial plexus palsy. So this is again 90-degree abduction and then trying to feel if at all there's contraction. So the basic principle of testing is that keep the limb in the position you want to test, because these patients can't do it by themselves. Okay. So serratus anterior you want to check, you have to keep the limb in this position. You can't tell the patient to do that because they are not able to abduct the shoulder and other muscles are paralyzed. So this is on the abnormal side. Again, absolutely no contraction. Divisions, there are no branches, there are no nerves. Okay, but anterior divisions go to the flexor side and posterior division goes to the extensor side. Now you come to the cords. So you have the cords, the thoracodorsal nerve, which supplies the latissimus dorsi. You have the lateral pectoral and the clavicle for the clavicular head of the pectoralis major. And then you have upper and lower subscapular, which supplies the teres major and subscapularis. So these are the muscles. And then you have the medial pectoral nerve for sternal head of the pectoralis, and then medial brachial cutaneous and medial antebrachial cutaneous. These are the branches. So this is the pectoralis major testing. Again, so basically you have two heads, the clavicular and the sternal head. So one goes right like this, clavicular head. The pectoral one will go almost like this and come towards the chest wall. So that is the adduction which happens here. That's what you need to test. Again, in this global palsy, absolutely no movements, and no patient is trying to do that, but no contraction seen. Okay, that is in the global palsy. Latissimus dorsi, a huge muscle here. Again, extension of the entire shoulder here, and there's a huge muscle here which is contracting here, and that is how you test that latissimus dorsi. And in a paralyzed, in a global palsy like this, again trying to feel for the contraction of the muscle, that is very, very important. And patient is trying to adduct and also extend the shoulder. So that's the action of the latissimus dorsi. Teres major, again you have the internal rotation happening here, and so you need to feel the border here, this border here of the scapula for the contraction. Once you come to the branches, basically the musculocutaneous, axillary, radial, median, and ulnar nerves. These are the testing we have done. Musculocutaneous basically for biceps, axillary for deltoid, and radial, median, and ulnar we have covered last time. So this is the basic testing of these muscles. Sensory dermatomes, all the postgraduates have to remember this. Definitely, if you don't remember, just paste this on your wall and always keep looking at it. Where is C5, C6, C7, C8, and where the T1 and T2 goes. So these are very, very important if you get a neurological case. Always, there are almost 70% associated injuries. So you can have head injuries, cervical, spine, thoracic cavity injuries in 20% of these patients. Spinal cord vascular injuries, very common, and musculoskeletal injuries, especially clavicular fracture, shoulder girdle injuries. Basically, any of this shoulder girdle can be fractured. So relevant investigations on day one would be X-rays, chest X-ray, shoulder X-ray, basically to rule out fractures. Cervical spine injuries, especially this patient, if you see the lordosis lost, lot of spasm. And here, chest X-ray is always done with deep inspiration. And then you have to see the level of the diaphragm. That's very, very important, especially in high injuries, like where the phrenic nerve component is involved, the C4, C3 components are involved. So then there could be a diaphragmatic palsy. So always take the chest X-ray in erect posture and with deep inspiration for these patients. Further investigations are always done about by 3 weeks. Please don't ask MRIs on day one. CT myelo or MRIs. A lot of patients carry MRI which is done on day one, absolutely useless because so much of edema and bleeding there. So you can't see any of these things. So by about 3 weeks, all these inflammatory processes are settled down and you can clearly make out the injuries. And the classical sign of preganglionic would be a pseudomeningocele. And even the NCV, again, it takes time for the nerve degeneration and regeneration to start. So Wallerian degeneration, hematoma resolve, all these have a reason why you need to do it at 3 weeks. We used to do CT myelo earlier to see the pseudomeningocele. MRIs nowadays show it very nicely. And the electro-diagnostic studies basically answers 3 questions. Is there any root avulsion? Very important for us to take a decision. What is the level and the type of injury and whether there's any recovery. Patient comes, so your NCV and electro-diagnostic studies are always a serial examination and you need to check whether there is any recovery happening or not. And we do both nerve conduction and EMG. Sensory and motor potentials are recorded and sensory evoked potentials can sometimes be used. So the classic root avulsion triad is a snap is normal because the relay is still there, and then but the sensory evoked potentials is absent. The denervation of paraspinal muscles plus spontaneous activity and complete absence of voluntary motor units in muscles innervated by the root, especially the dorsal paraspinal muscles. These are denervated with this. Coming to just basic principles of management. Acute cases, absolute indications are open injuries and vascular injuries. That is the time we go in. Otherwise, if it's a closed injury, there is no hurry to go in and do anything right now. So open injuries, vascular injuries, obviously you'd go and explore. But if it's closed injury, basically non-operative method, treat other associated injuries, but continue passive mobilization of the limb, all the joints, especially electrical stimulation. Nowadays, home kit is available. It costs about 3,000 rupees. They can order on Amazon, and they can just you teach them how to simulate the muscles, which they can do it daily at home. Pain management, as I said, they might have a lot of chronic pain. So very important for pain management. Very, very important to have psychological and family support. Counseling is important. Education about the condition itself is important. People just don't know. Orthopedic surgeons, a lot of them don't know what to do on day one and in the beginning, and they get MRIs done and all, which is not useful actually. Splints if required, especially in a global palsy, the hand they keep like this in a sling, and they start developing MCP stiffness and wrist stiffness. So make sure you take care of all those things. Criteria for continuing non-operative management is postganglionic injuries, if there is a progressive motor march, if there's a progressive tinal sign. So these are the things you need to remember, especially postganglionic injuries. You can wait and watch for some time. If it's a neuropraxia, usually 6 weeks they start recovering. So surgical management, especially preganglionic injuries. So clinically this preganglionic, there is Horner syndrome and other signs, and your MRI at 3 weeks might show pseudomeningocele. Definitely you need to go in early. There's no point in waiting in preganglionic injuries. Postganglionic injuries without progressive recovery after 3 months. It starts recovering, but then it stops. You need to know that's a motor march. From shoulder down, it should start progressively moving. But if it's not, there is some problem is there. You need to check. Then non-anatomical return of function. So sometimes you have very distal recovery. C8, even there's some recovery, but shoulder is not recovering, elbow is not recovering, especially in global palsies. You need to start thinking why, and there could be mixed type of injuries. So the basic aims is, most important is trying to get elbow flexion in these patients, shoulder stability, which is abduction and external rotation movements, sensation, especially median nerve territory. This is where most of our work happens, in the radial side of the hand. So median nerve territory sensation, and of course finger flexion. But if you can get other things also, it's well and good. So 2 groups of surgeries we do. Basically, one, we're targeting the nerve itself. Second is we are targeting other areas like tendons and joints. So secondary surgeries for restoring the function. So primary concern is always, can we do a nerve surgery? So it all depends on when the patient comes to you. Earlier the patient, better chances to do nerve surgeries itself. We can do a direct repair. We can do neurolysis. We can do nerve grafting. And we do what is called as nerve transfer, which is called as neurotization. Within the plexus or outside the plexus. So these are the options for nerve surgeries itself. Acute cases, as I said, open injuries and all, neurography is possible. Fresh gives excellent results, obviously. This is the same assault patient I showed you. And then, so you see that it's completely transected C5, partially injured C6. So that is repaired, primary repair. So that is the function. So you get complete full abduction for the patient and good results, especially in acute injuries. But if you see that there's a lot of scarring, even if the patient comes a few weeks later, there'll be a lot of scarring. So that is the time we do what's called neurolysis. But isolated neurolysis a lot of times is not useful. You have to check. Intra-op, we use nerve stimulator and we check and see if there's any doubt. You have to resect the neuroma there, and then you might have to do a nerve grafting there. So neurolysis is always possible. When you have your nerve stimulator and you know that after neurolysis your muscles are working. So very, very important. Presence of conduction of the neurolysis, if there's a neuroma in continuity, okay. But if there's an absent conduction, you have to resect the nerve and do a nerve grafting, as I said. And it's rarely done in isolation. Okay, always use a nerve stimulator. So this is the results of, this is the paralyzed site for this patient. And this is the result after the neurolysis. So patient has got back the elbow flexion there nicely, okay, and also the abduction to a certain extent. So that is neurolysis. So when you do nerve grafting, so if you have a lot of fibrosis of median and fibrosis of the nerve itself. And when proximal stumps are available and you have a gap because of either resection of the neuroma or any of these, then you have to do a nerve grafting. And especially in ruptures, as I told you, where you have the axons which is still attached to the spinal cord, it is available, and then you can go in and bridge that gap by doing it. This is one of the greatest advances in brachial plexus injuries. So that is the nerve grafting. Commonly, we use sural nerve grafts we use in these patients. And sural nerve, why? Because you get a lot of length, almost 30 to 40 centimeters of length. It could be medial cutaneous nerve of the arm, forearm, or other things. There are other donors also available. But otherwise, sural nerve gives a good length of graft, and we use cable grafts. So we require a large length, and that's what the sural nerve gives. We ask this question always: what is nerve transfer? Nerve transfer is an transfer of an intact or functional nerve to a non-functional or paralyzed nerve with more important function. So you're talking of transfer of an intact nerve, but that intact nerve can be spared. So that is what it is, and that is the only solution for avulsion injuries. As I said, it could be inside the plexus. You can use branches within the plexus, or you can use branches outside the plexus. So this is a patient pre-op, again, upper brachial plexus injury. This is the normal side. Other side is paralyzed here. No abduction, no flexion here, right? And then you see the amount of root level fibrosis which is happening at this point. Poor quality proximal stump in this patient. So for the shoulder abduction, we go and use that radial nerve branch to the triceps long head, and that goes to the axillary nerve branch. So triceps has multiple branches. So we use one of the branches and then transfer it to the axillary nerve. So that is a bit more important function now. So that is what is done there. And this is one of the classical nerve transfer for elbow flexion here in this patient, what we do routinely, which is called as the Oberlin's transfer. Here, a vesicle of median and ulnar nerve is taken, and it is given to the nerve to biceps here from the musculocutaneous nerve. So it's a very short transfer here. So the axon has to travel only a very short distance. So the patients start developing elbow flexion very soon. A branch is also given to the brachialis, so they get good amount of elbow flexion. So that is the same patient, and this is the result of this. So this was the paralyzed side, and so you can see that the elbow flexion coming nicely with this, with the Oberlin's transfer, and also the shoulder abduction also. So it gives very gratifying results for these kind of things. The other one is spinal accessory to suprascapular. You know the spinal accessory is a cranial nerve. It supplies the trapezius also. So one branch of the trapezius goes to suprascapular for you to get the supraspinatus function, and again shoulder abduction. So that is again a very short transfer. Now taking branches from outside the plexus is intercostals. These are very common donors which we use. We use at least 3 or 4 of these intercostals, and then the same, it can be given to either median nerve or musculocutaneous nerve. Median nerve basically for sensation, which I told you, and the motor goes for the musculocutaneous. So couple of intercostal muscles can go here for these. If we don't have any donor in the plexus itself, we can use this as a donor here. So this is again a global palsy here, and with root level injury, an intercostal was used for elbow flexion, and spinal accessory was given to suprascapular. So, and then wrist arthrodesis was done. So patient is getting some amount of good elbow flexion here, and also the wrist is stable now. So even if he gets a hook kind of a grip, patient is quite happy instead of having a completely flail limb in these patients. Secondary procedures are helpful in delayed or late cases. Always remember, if patient comes early, all these are possible, generally within 9 months maximum. The later the patient comes, all of these nerve transfers and other things don't work very well. So especially adults. In a child, it's a totally different thing. But in an adult, 9 months probably is the time when you get good results. Can push up to maybe a year, but otherwise beyond that, there's absolutely no hope to do a nerve surgery itself. Secondary procedures, all of us have been doing from many years. So tendon transfers in shoulder, like trapezius transfer, elbow or wrist, latissimus dorsi to elbow, and again wrist, arthrodesis of the shoulder and wrist. We don't arthrodese elbow. Elbow we try to give as much as possible a functional elbow, but shoulder and wrist can be arthrodesed. So to give that elbow flexion or a finger flexion, one of the options now we have is a free functioning muscle transfer. So we transfer the entire muscle along with neurovascular bundle to to a recipient area. Like you want biceps function, we can transfer the gracilis to the biceps area. So this is an example of shoulder fusion. So some amount of stability they get. If this elbow was transferred, nerve transfer was done. Shoulder, we fused it, so they get some amount of stability. The scapulothoracic muscles work here, and that is good enough for their most of their activity. And this is the gracilis. So the gracilis was transferred to the instead of for the biceps, the gracilis was transferred. So patient starts getting some amount of movements because of the gracilis now working here in this particular position. So this is how the treatment has advanced for these kind of patients. So in summary, differentiate between rupture and avulsion. That's very, very important. So the management changes between rupture and avulsion, very important. Very, very good documentation is important. Whatever clinical examination I've showed you, very important for you to differentiate between preganglionic, postganglionic, and then so you can plan your management. Most of the investigations are useful by 3 weeks. Please don't get MRIs and other things on day 1, which is absolutely not necessary at all. Early nerve surgery, very, very important. So it means that you have to be aware what possibilities are there for treatment. And so that you tell even your own colleagues to refer early with these patients wherever this work is done. So that I see patients being asked to wait for 1 year, 2 years, it will recover. Nothing happens for these patients. They keep roaming around in different places. Free muscle, tendon transfers, arthrodecies are viable options in late cases. So options are still there, but the results might not be. But then these patients, they don't have anything. In a sense, the entire limb is paralyzed. So even if you give something back to them, it's a lot for the patient, and that's what patients want. Thank you so much for your attention.
Thank you, Anil. That was great. I'm sorry I missed the first 10 minutes or so because I was stuck in a traffic jam just literally 5 minutes from my house. And I thought I was making good time and then I got stuck. So anyway, questions from any of the DNB students? I hope you all understand what he means by neurotization. Sachin, you there?
Yes, sir.
So explain to me what he means by neurotization.
Sir.
Sorry?
Sir.
Yes.
Yes, Sachin, that is nerve transfer. So what do you mean by that?
Sir.
Like the way we do tendon transfers, right? So we use something which is less important in that sense, or might have duplicate actions, right? And then we use it to the more important area. So a nerve transfer basically means you have some nerves which can be spared, like intercostals. You have 12 intercostal nerves, so you can use a couple of them and give it to a place where you require more important function, like biceps function or sensation, any of these things. So that is so. But then the donor nerve should be still connected to the cord. That is the most important thing here. You can't just take that; then it becomes a nerve grafting. So a nerve transfer is where it's still connected to the cord, and you're just shifting it to an area where it's required. So as I said, spinal accessory to suprascapular. Spinal accessory nerve is supplying the trapezius. It has 3 or 4 branches. So we take just one branch of this as it comes here, and it's very close here to the suprascapular notch. That is where the suprascapular nerve is going. So we connect that spinal accessory branch to suprascapular. So the supraspinatus starts working now. Patient starts getting the abduction of the shoulder, right? Now, if the upper brachial plexus C5-6, so the radial nerve is intact. So we take the radial nerve, one branch of the radial nerve, and transfer it to the axillary nerve here in the back, in the triangle area here, okay, or the quadrilateral space there. So it's a short transfer. So one branch of the radial nerve, the long head branch is taken. Triceps don't get denervated because of that. So we just take one branch and then give it to the axillary nerve. So now the deltoid will start working. So this is the strategies we use to get a function back to these patients. So we are looking at elbow flexion, we are looking at shoulder abduction and external rotation, because these are what is for our daily activities we require these functions. So this is a strategy we use.
Yeah. Someone's asked a question as to why axonal reflex is present in preganglionic lesions.
Yeah, it's only the flare response which is still present, because you see it's the ganglion is still intact, right? It is the entire thing is avulsed. The ganglion is outside. The dorsal relay is still there. So when you do the scratch test, your flare response, it goes there and comes back, so that circuit is still intact, right? So that is why it is still present.
And there was another question as to how much tension is required while suturing the graft. How much tension?
Okay.
As less tension, I guess. Yeah.
When we use the sural nerve, we make it into small pieces, basically like a cable. We call it cable graft, because you have these nerves which are big, quite thick. So you have to cover as much of the circumference as possible. So we connect multiple of these cables, right? And they need to be quite lax. If you're talking of nerve suturing tension, that is a different thing. That is end-to-end repair, right? If you do a primary repair, a neuroraphy, that is where tension matters, because there, if you suture it under tension, it leads to fibrosis. Okay. So one of the classical thing is, if you use a 6-0 suture and take a knot, take a bite, and then try to tie a knot, it should stay there. That is one of the criteria. If it doesn't and comes away, means there's a lot of tension. Second, in a peripheral nerve, we go by the rule of thumb, just anything above an inch, right, means there will be a lot of tension. You might have to use a graft if the gap is more than an inch. Okay. Sometimes we flex the joints. Like if you're suturing a nerve here, you flex the joint, relax the joint, and then try to suture. But you can't flex it like this and then suture. That will be a lot of tension. You can't get it back again. So we mobilize the nerve by tissue dissection, because the nerve has a lot of connective tissue tethers. So we can mobilize the nerve. You can change the position of the joint, right? All these are methods to reduce the gap there. In spite of this, if you can't and there is a gap there, you have to use a graft. And when you use a graft, make sure it is very lax. It's not very, tight there.
So the idea is that you suture it in as little tension as possible. Okay. So when you're repairing a nerve, you don't want the ends to be yanking at each other. To some extent, you can reduce the tension by flexing a joint, but if you extremely flex it, then it becomes a problem. So you should at least be able to get it to close to neutral position with reasonable tension. Okay, the tension has to be less, not more.
Another question is about the birth brachial plexus palsy. What is the prognosis here?
That's a completely different topic.
Yeah.
So again, children do much better compared to adults. That is first thing. The distance is shorter for the nerve to grow. So you know that children are small, the length of the limb is small. So that's why I said, even if the child comes a little late, you can still do now, because the distance to travel for the axons is also less. Second. Third is, of course, in terms of, again, there also we nowadays tell as early as possible. So we look at anti-gravity muscles like biceps. If biceps doesn't recover by 3 months, means there is a problem. So they might recover a little here and there, but the quality of recovery is not good. So earlier intervention is better in these children. So we always tell the parents, because here it's a child and they're very scared that you're going and operating near the neck and all those things. The pediatrician's role is very, very important. So the pediatrician should know that there are options for nerve surgeries nowadays and microsurgery. So they should be telling the patients, the parents, that if the child is not recovering well, we give the time between 3 to 6 months. Anti-gravity muscles, biceps, wrist, all these, they should, if they don't show any signs of recovery, means the child requires exploration and whatever procedure, whatever I told you, there could be nerve grafting required, nerve transfer required, any of these. But pre-ganglionic, there's no point in waiting in either child or adult. As early as possible, you have to go and intervene. because they will never recover because they have all pulled off from the cord itself.
Yeah, so the Erb's palsy, which is probably the most common of the birth palsies, today there is generally a fair deal of acceptance that at 3 months active flexion of the elbow should come back, because a lot of them do recover on their own.
Yes.
If they do not have active flexion of the elbow by 3 or latest 4 months, they should undergo surgery, because the earlier you do the surgery, the better it is in terms of the recovery.
Correct.
But then it has to be done by someone who's experienced in that surgery and not by anyone else.
Yeah.
Those are very specialized surgeries, because especially in a child, the anatomy, etc., you have to be aware of it. The anesthesia is important, okay, because these take time. So you must have a anesthetist who's experienced in giving small children anesthesia, because this is 2 months, 3 months, 4 months.
Correct. And anesthesia also, they sometimes use short acting muscle relaxants, because we stimulate the muscles in between during surgery. So they should know all these things about how to give anesthesia, and as sir said, long-term anesthesia, it goes on for 6 hours, 8 hours. Hypothermia is a problem in these children when you take for them for surgery. All those things to be taken care of. Only a good anesthetist knows all these problems and complications. So it's very important to have a good setup, an ICU setup post-op especially. Sometimes they might not like to extubate because the child has been under anesthesia for a long time. They will wait for a day. So all these things are there. It's not a straightforward thing.
So you mentioned about that birth palsy is more common of type. So in case of adults, sir, which one you find more common? So it's
no, majority are again upper brachial plexus. Majority of
is more common.
Yeah.
But you can have complete. It's not in severe injuries. You'll have a complete
global kind of a thing.
Global involvement. Yeah.
The CAT one is the least common, just the lower root avulsion. But because they are deep inside, so it takes a lot of energy for it to be avulsed, and again sparingly. So the mechanism is different in that traction versus acceleration kind of injuries and other things. But otherwise, upper brachial plexus and global palsies are common.
There's another question: injury in the canal, which is technically post-ganglionic, but we have very less proximal stump available. In that case, do we plan tendon transfer, or do we attempt to repair the nerve?
Yeah. So I mentioned in my slide also, some of the post-ganglionic injuries could be global palsies, which is what you have told now, which is very high injury. They are not avulsion technically, but they're very close to the foramen, and you don't have enough proximal stump for you to go and do anything. In that case, you need to treat it like avulsion, which is the plan is nerve transfer. Okay. Only if patient has come late, we talk of tendon transfers and all those things. But otherwise, you can't do nerve grafting here. Again, the same problem. It's too high. It's almost near the foramen, right? So you have to talk of nerve transfer. So the answer for avulsion should be nerve transfer. Okay, and for post-ganglionic rupture kind of injuries, it has to be either direct repair if possible or nerve grafting. That should be the answer. Yeah.
One more question is.
Good evening, sir. Sir, for demonstrating tinel sign here, from where we should start percussing, sir? From distal or proximal, sir?
Here, the tinel sign is different than what you're talking about nerve recovery. When you talk of nerve recovery, we always do from distal to proximal. Yes, here, sir, what I showed, the tinel sign here in the root of the triangle here is basically to check if there's any kind of impulse happening there for you to know if at all there are any viable axons. So the tinel sign in that sense is a different concept here. See, you talk of, some people tell tinel sign for carpal tunnel. Okay, here the nerve is not damaged. You're not looking at recovery of the nerve here. If you tap for the carpal tunnel, then also patient will complain of tingling. So that tinel sign is different. Here again, what I'm talking here is if patient has some amount of tingling or numbness happening there, or paresthesia, means the axons are intact. Probably it is not a root avulsion. That's all it tells, nothing else. It's not, they're not talking about recovery here.
Okay, so where they'll feel paresthesia, sir, if are percussing near the neck?
In the triangle here, the posterior triangle here, where the nerves are coming off and they come towards the anterior triangle here, that is where you will get that.
Okay, sir. Thank you, sir.
So one more question is there, sir. What is about the in repair? Is it better than into site suture?
An end-to-end is always a better
Always
option.
better, no?
Yeah, you have more
That is
axons, more blunt vesicles for you to this. End-to site are used in very certain situations. Sometimes we use it in partial injuries or some specific indications. It's not always possible to do an end-to site. Okay, but if you have a nerve completely cut, an end-to-end would be obviously the best option.
So, there are a few questions which was asked previously in the DNB examination, about the classification of brachial plexus palsy. So in that case, sir, which classification the candidate should write? That one, like you have told about the preganglionic and post. And one more confusion about that, sir. Preganglionic and supraganglionic is same, no, sir?
Yeah,
That
we don't really use the word as supraganglionic. The correct terminologies are pre and postganglionic. See, each one is talking different things. So if you talk of preganglionic and postganglionic, it tells you where is the problem, right? In the terms of the mechanism itself, in terms of the prognosis also, in terms of the management also. So that is the most important, clinically, for you to manage a patient, that is the most important classification. Next is the level. So whether it is upper, lower, or global palsy. Okay. So generally the preganglionics fall into global palsies most of the times. Okay. So because the injury impact is so much, they usually have a global palsy, right? But otherwise, you have to examine and see whether it's upper brachial plexus, extended upper brachial, which is C5, 6, 7, or it's a global palsy, or it's just C8, T1. That's just for you to know the level itself. But for your management, the most important aspect is pre versus post. Can you wait or you don't wait? In preganglionic, you have to think of nerve transfers. In postganglionic, you know there is an option for nerve transfer and other things.
Yeah, and there's also so yeah, essentially, practically, those are the most important things to look.
Yeah.
And like, sir, in classification, they should mention about herbs, clump case, whatever the according to name also. When they ask for a classification of brachial plexus palsy,
it's more of eponymous thing, and again, it's more of, we use the term herbs and all those things classically for birth palsies.
Birth palsies,
yeah. Clump case and herbs. So those are all classical eponymous kind of names given. So I think you basically talk about the mechanism of injury itself and the prognosis, and that gives a better classification idea.
Yeah.
And so one question which was asked previously is about the management of brachial plexus injury in orthopedic supracondylar fracture associated with supracondylar fracture. So in that case, what we should try?
Which supracondylar?
That they have not mentioned here. Management of
brachial plexus injury management is independent of what you do for the distal humerus fracture. Yeah.
Okay.
Did they mean brachial artery injury with supracondylar?
Maybe so, because they have asked it in the DN.
More likely that if there's a brachial artery median nerve injury along with it, that's a different situation.
Yeah. Otherwise, it doesn't really make sense with that.
Yeah. And another.
But that's not surprising for DNB questions not to make sense sometimes.
So then you talk of brachial plexus injury management plus supracondylar separately. That's all. The candidate, I think, the only thing they have to do, unless they clarify in the exam hall what is the question.
And so you have mentioned about the Wallerian degeneration. So they have asked that twice or thrice in the TNB. So for that one, sir, about the definition and pathophysiology, they have.
That's a physiology question. You should have read it in your physiology.
So basically, you know that once there is an injury, the nerve cell itself undergoes nucleolysis and all those things. So then that entire tube gets empty. Basically, the axon dies, which means that the axonal flow is absent, the axoplasm is absent. So unless this is classically happens with neurotomesis kind of an injury, right? That is where it becomes more relevant also. So till you put them back, so the nerve cell will start, obviously it will start recovering and start the growing back. So the degeneration is the first step, and then the regeneration starts. So this entire process takes about 2 to 3 weeks or almost a month. That's why even our NCVs and all are done after 3 weeks or a month. Okay, so even in a peripheral nerve injury or any of these injuries, the natural healing is obviously that the nerve cell starts recovering once the initial insult is over. That is the Valerian degeneration part, and then the axons will start growing. So where the axons have to grow is the most important thing. Now, if it's an axonotomesis, if the sheath is intact, the axons will grow back. But if the neurotomesis, unless you put it back, there's no way. So then the neuroma forms. Okay. So this process of cell death and then regeneration. So that is the entire thing. I think they should write from the Ganong nicely about this. If they're reading Ganong nowadays.
About this thing, sir. In case of management, sir, previously it was described like amputation is also one of the management of brachial plexus injury. So during the clinical viva, sir, they can mention it that in the last that
amputation is for that last D, damn news, right? Dead limb, dangerous limb, all this. So the damn nuisance is the last indication for amputation. The nuisance limb, which means that one global palsy, not recovered, patient not taken any treatment or treatment has failed. Plus, most important thing is very, very chronic and severe disabling
phantom
pain.
limb, etc.
Yeah. Pain is a very, very, so they'll have this causalgia kind of severe pain, and patients have to ask for the amputation. You don't offer amputation for these patients. Patients should request for amputation. Then only it's worthwhile. Because even after amputation, they can still get pain.
Phantom limb, yeah, exactly. Yeah, that's right.
So it's a nuisance limb for the patient. It is hanging by the side, completely flail, and comes in the way of all activities. Patients don't have sensation here. They might develop ulcers or burns and other things. Plus the pain itself, which it's not relieved by anything. They have suicidal tendencies sometimes because of that, right? So that is the thing. But then you can't really assure that even with the amputation, that pain might go away. So people have gone all the way till the dorsal root to ablate the dorsal root. So many procedures are there where people have gone to the spinal cord and tried to close that pain pathway, the gateway of the pain itself. So many surgeries, rhizotomy, other surgeries are available for that.
Our next question is about that one, sir, about the recent advances. What are the recent advances in that one?
In brachial plexus injury itself, right? So injuries, the greatest advantage, as I told you, was nerve grafting. So that is what changed the whole thing. So when people started using the nerve grafts liberally, that is how the things changed. Then came the nerve transfer, concept of nerve transfers. The third point people should talk about is the free muscle transfer itself.
Yeah.
Okay. And then now we have what's called as nerve conduits nowadays. So you have a gap, we don't put nerve graft, you use nerve conduits, which are basically ready-made kind of conduits available with nanoparticle inside, which has growth factors. So neurotropic factors where the axons are allowed to grow in through that. So you don't need a nerve graft. You can bridge the gaps with these nerve conduits, artificial nerve conduits. So these are the new things which are coming up. So that is packed with nanoparticles that carry the neurotropic factors. So the axons will grow in that same path and reach the opposite side. So you don't need large nerve grafts for these. So these are the things, newer things which are coming in. Plus, as I said, spinal cord surgeries, basically for pain. Okay. So these are the things which are the recent advances.
What you have mentioned about the nerve conduit, that one is available in our country, sir?
No, not yet.
So I think most of the things.
I think that's great. Thanks very much, Anil, as usual.
Thank you so much.
Excellent presentation, and I'm sure the students would have gained. I think we learn quite a lot when you give us these talks as well. So it's always a pleasure. Thanks a lot, Anil. Yeah, okay.
Thanks for the invite, sir. Thanks, Janki. Thanks, sir.
Bye,
Thank you so
everybody. Until next week. Okay, bye.
Thanks.
Bye.
Thank you, sir.
Well,